Welcome to the Deep Dive, the show designed to cut through the noise and give you that shortcut to being truly well-informed. Today, we're embarking on, well, an extraordinary journey. We're diving into one of the most vital and complex regions of your body, the brainstem, and also the intricate bony fortress that protects the skull. Our mission, as always, is to go deep. We want to unpack these layers of complex neuroanatomy, not to overwhelm you, but really to provide a clear three-dimensional picture. Understand the what and the why, and uncover some surprising facts and crucial insights. The goal here is mastery, like the elite professionals in the field.
It's a fascinating area. What always strikes me about the brainstem is the sheer density. You've got all these critical pathways, these nuclei, packed into such a tiny space. And understanding their precise locations, how they connect, it's absolutely foundational, not just academic, but for understanding neurological health, disease. As you'll see today, seemingly small anatomical details here can have profound, really widespread clinical implications. Grasping that connection, that's the key to unlocking true mastery of this subject.
Okay, so to really hammer home the significance, let's start with a real-world puzzle, a clinical case. Imagine a 58-year-old woman. She goes to her neurologist because, quite recently, she started having trouble walking. It's really concerning her. Now, during the examination, her posture and the way she walks are quite telling. Her left arm is held flexed at the elbow, and her left leg is stiffly extended. That pattern, that's what we call left hemiparesis, weakness on that left side.
Right. And when she tries to walk, you see the difficulty. She struggles to bend her left hip and knee properly. And lifting her foot, dorsiflexing the ankle, is hard. So to avoid dragging that foot, she actually has to swing her left leg outwards in this wide arc. And all the while, that left arm just hangs there, motionless.
Okay, so the neurologist is noting all this.
Yeah.
What else comes up in the exam?
Some very specific, very crucial findings. First off, no facial paralysis. That's important. But her tongue. Definite weakness there. When she's asked to stick it straight out, it consistently deviates, sharply, to the right side.
To the right side? Up.
Yes. And that specific deviation, it's a classic sign, points directly to a right hypoglossal nerve palsy. Then, looking at sensation, her superficial touch, like light touch, is normal, but the deeper senses, things like muscle joint sense, knowing where her limbs are without looking, tactile discrimination, distinguishing between 2 points touching her skin, and vibratory sense, all of those are significantly impaired, but only on the left side of her body.
Wow. Okay, so if I'm piecing this together, each of those distinct findings, the arm and leg weakness on the left, the tongue going to the right, that specific sensory loss, again on the left, they must all be pointing to something very precise, right? It's like a neurological detective story. Every symptom is a clue.
Exactly, you've hit it. When you meticulously sort through those precise findings, they converge. They lead you directly to a diagnosis, right-sided medial medullary syndrome. And this kind of pinpoint diagnosis, it's only possible if you have a really clear, deep knowledge. You need to know exactly where these nerve tracts and nuclei are located within the medulla oblongata and what they do. Let's break it down. See how each symptom maps perfectly to a specific structure in the medial part, the inner part of the right medulla. An area, by the way, that's primarily supplied by the right vertebral artery.
Okay, let's map it out. The left hemiparesis first.
Right. The weakness on her left side, that's directly explained by damage, destruction of the right pyramid. Remember, the pyramids are packed with corticospinal fibers. These are the direct motor commands coming down from the brain's motor cortex. They control your voluntary movements. And the vast majority of these fibers, they cross over to the opposite side of the body right there in the medulla. So damage the right pyramid, you lose the motor commands going to the left side of the body.
Makes sense. Okay, what about the tongue deviating to the right?
That's the right hypoglossal palsy. It points straight to destruction of the right hypoglossal nucleus and nerve. The hypoglossal nerve, CN12, directly controls the tongue muscles. So if the right side is weakened, the stronger muscles on the left side basically push the tongue over towards the right, the weaker, paralyzed side when she tries to stick it out.
Got it. And the sensory loss.
Yeah.
The impaired joint sense, vibration, discrimination on the left.
That's all linked to damage of the medial lemniscus on the right side. The medial lemniscus is a critical ascending sensory pathway. It carries those specific, finely tuned sensations, proprioception, vibration, fine touch up towards the brain. And just like the motor pathways we discussed, these sensory pathways in the medial lemniscus also cross the midline. So a lesion on the right side affects sensation on the left side.
And you mentioned what wasn't affected was also important, no facial paralysis.
Exactly. That told the neurologist that the facial nerve nuclei and their pathways were intact, spared. Similarly, the fact that her general touch, pain, and temperature senses were normal, that indicated the spinal lemniscus, which carries those sensations, was also okay. So this case just beautifully illustrates it, doesn't it? How a deep understanding of neuroanatomy isn't just memorizing parts. It's about solving real-world medical mysteries by pinpointing these tiny, specific lesions.
That really is a powerful example. It shows how understanding these intricate connections lets you zero in on the exact problem. It turns this complex set of symptoms into a, well, highly localized puzzle. So with that compelling case setting the stage, let's formally introduce this incredible region of the brain, the brainstem itself.
Right. The brainstem. It truly is a foundational part of our central nervous system. It's made up of three main segments. We just highlighted the lowest one, the medulla oblongata. Above that sits the pons. And topmost is the midbrain. Anatomically, think of it like a stalk. It connects the spinal cord below to the forebrain above, and it's nestled down in a very specific, very crucial space within the skull, a compartment called the posterior cranial fossa.
And it's not just a connector, right?
Yeah.
What are its core functions? It must be doing some serious heavy lifting for our basic survival.
Oh, absolutely. It's essential. The brainstem serves three broad, critical functions. First, it acts as a conduit. Think of it as the body's neural superhighway. It's the pathway for all the ascending sensory tracts, carrying information up from your body to higher brain centers. And it's the pathway for all the descending motor tracts, carrying commands down from your brain to your spinal cord to control movement.
So information traffic control, what else?
Second, it contains absolutely vital reflex centers. And we're not talking simple knee-jerk reflexes here. These are fundamental for life itself. Centers that automatically control your respiration, making sure you breathe without thinking about it. Centers that regulate your cardiovascular system, managing heart rate, blood pressure. It also plays a really significant role in maintaining consciousness, keeping you alert and aware.
Wow, okay, conduit, vital reflexes. What's the third function?
Third, it's a major hub for cranial nerve nuclei. It houses the nuclei, the control centers for cranial nerves, the third, all the way through 12. These nerves handle a huge range of functions, everything from eye movement, facial expressions, swallowing, taste, to even regulating internal organs like your heart and lungs via the vagus nerve. So yeah, if you connect this to the bigger picture, the brainstem is truly the body's fundamental control tower for life-sustaining processes. And at the same time, it's a major communication hub, sending and receiving signals for everything from basic sensation to intricate muscle control.
Okay, so this incredibly vital brainstem and the rest of the brain is housed inside the skull. But as you hinted, the skull isn't just a simple hard shell, is it? It's much more intricate.
Oh, far more. It's an incredibly engineered structure. The adult skull isn't one single bone. It's composed of several separate bones, all tightly joined together by these immobile joints called sutures. You might know names like the sagittal suture, running front to back on top, or the coronal suture, running side to side. The only major exception to this immobility is your lower jaw, the mandible. It connects via the mobile temporomandibular joint, or TMJ, allowing you to chew, talk.
And the bone itself, what's its structure like?
It's very resilient. The bones of the cranium have an interesting layered structure. There's an external table of compact bone and an internal table, also compact bone. And sandwiched between them is a layer of spongy bone called the diplo. It's like a bony Oreo cookie. An important point clinically is that the internal table is generally thinner and more brittle than the external one. This matters in cases of head trauma.
Okay, let's get into the specifics. Because you mentioned even subtle features, openings, ridges. Tell us something important. Let's start with the anterior view. Looking at the skull from the front, what are the key landmarks?
All right, from the front, the most obvious thing is the frontal bone. That forms your forehead and also the upper margins of your eye sockets, the orbits. Below the frontal bone, you have the two maxillae. These form your upper jaw, hold your upper teeth. They also form parts of your hard palate, the roof of your mouth, and contribute to the sides of your nasal cavity and the floor of your orbits. And inside the maxillae are the maxillary sinuses. These are large, air-filled spaces lined with mucous membrane. They lighten the skull, resonate your voice, and connect to your nasal cavity.
Okay, what else from the front?
You've got the zygomatic bones. Those are your cheekbones. They form the prominence of the cheek and also contribute to the side wall and floor of the orbit. Centrally, of course, are the nasal bones, forming the bridge of your nose. These, along with parts of the maxillae, frame the anterior nasal aperture, the bony opening to your nasal cavity.
Got it. Okay, let's rotate the skull now. To the lateral view. What do we see from the side?
From the side, a large portion is formed by the parietal bone, making up much of the side and roof. It meets the frontal bone anteriorly at the coronal suture, and the occipital bone posteriorly at the lambdoid suture. The temporal bone is also a major player on the side. It's complex. It includes the opening for your ear, the external auditory meatus. It also has the mastoid process, that bump behind your ear, and the zygomatic process, which arches forward to meet the zygomatic bone, forming your cheat arch.
Now, you mentioned earlier there's one spot on the side that's particularly important clinically, thin bone.
Ah, yes, absolutely critical. That's the opterion, P-T-E-R-I-O-N. It's typically an H-shaped formation of sutures where four bones meet, the frontal, parietal, temporal, and the sphenoid. And it marks the thinnest part of the lateral skull wall. But the real reason it's so critical is what lies directly underneath it, on the inner surface. The anterior division of the middle meningeal artery. It runs in a groove right there. So a blow to the side of the head, right at the temple, at the criterion. It can easily fracture that thin bone, and if the bone breaks, it can tear that artery. That leads to bleeding between the skull and the dura mater, the brain's outer covering. That's an epidural hematoma. It's a surgical emergency because the accumulating blood puts pressure on the brain. Very dangerous.
Wow. Location, location, location really matters there.
Right.
Okay, spinning around to the posterior view. What's prominent from the back?
From the back, you're mainly seeing the two parietal bones meeting superiorly at the sagittal suture, and below them, they meet the occipital bone at the lambdoid suture. The most noticeable feature on the occipital bone back there is the external occipital protuberance. It's a bump, sometimes quite prominent right in the midline. You can often feel it at the back of your head. It serves as an attachment point for neck muscles.
All right, now let's go inside the skull, into the cranial cavity itself. This is the brain's direct container. How is it organized?
Okay, the cranial cavity. As you said, it contains the brain, its protective membranes, the meninges, along with cranial nerves, arteries, veins, and those large venous sinuses that drain blood from the brain. The floor of the cranial cavity, the base of the skull viewed from inside, is beautifully organized. It's not flat, it's stepped, divided into three distinct levels or fossae. The anterior cranial fossa, the middle cranial fossa, and the posterior cranial fossa.
Okay, let's take them one by one. The anterior cranial fossa.
This is the highest level, the most forward one. It basically lodges the frontal lobes of your brain's cerebrum. It's bounded at the back by a sharp ridge formed by the lesser wing of the sphenoid bone. A key feature in the floor, right in the middle, is the cribriform plate of the ethmoid bone. Cribriform means sieve-like. It's perforated by lots of tiny holes, and through these holes pass the olfactory nerves, your nerves for smell, coming up directly from the nasal cavity below to connect with the olfactory bulbs of the brain, which rest right on top of this plate.
Fascinating. Okay, moving down a step to the middle cranial fossa. You said this one's more complex?
Yes, it's quite intricate. It's shaped a bit like a butterfly, with a narrow central part and two broad lateral wings. It lodges the temporal lobes of the brain. It's bounded anteriorly by those lesser wings of the sphenoid, and posteriorly by the upper borders of the petrous parts of the temporal bone's dense, rocky ridges. This fossa is like a major junction box. It's absolutely riddled with important openings or foramina for nerves and blood vessels entering or leaving the skull.
Give us some key examples.
Okay, well, right up front, connecting to the orbit, you have the optic canal. That transmits the optic nerve, CN2, carrying visual information from the eye, along with the ophthalmic artery. Just lateral to that is a larger slit, the superior orbital fissure. A whole bunch of nerves pass through here to control eye movements. The oculomotor, CN3, trochlear, CN3V, and abducens, CNC's nerves, plus branches of the trigeminal nerve, CNV, for sensation around the eye. Then, moving back a bit, there's the foramen rotundum, transmitting the maxillary division of the trigeminal nerve, and the foramen oval, transmitting the mandibular division of the trigeminal nerve. These are huge sensory nerves for the face. Critically, there's the foramen spinosum, a smally hole, but vital because it transmits that middle meningeal artery into the cranial cavity, the same one vulnerable at the criterion.
Ah, so that's its entry point. What else?
There's the carotid canal, though its opening isn't directly in the fossa floor. The internal carotid artery emerges from it here to supply a large part of the cerebrum. And right in the center of the middle fossa is the sella turcica. That means Turkish saddle. It's a deep depression in the sphenoid bone that cradles the pituitary gland. Very important endocrine structure.
Incredible amount of critical infrastructure packed in there. Okay, now let's move down to the deepest, most posterior level, the posterior cranial fossa.
Right. The posterior cranial fossa is the largest and deepest of the three. It lodges the hindbrain. That includes the cerebellum, the pons, and our primary focus today, the medulla oblongata. Its roof isn't bone. It's formed by a strong fold of dura mater called the tentorium cerebelli. Think of it like a tent stretched over the cerebellum, separating it from the occipital lobes of the cerebrum above.
And what are the major openings in this fossa?
The biggest and most obvious one is the foramen magnum, the great hole at the very base of the skull. This is the crucial transition point where the medulla oblongata exits the skull and becomes continuous with the spinal cord. It also transmits the vertebral arteries going up to supply the brainstem and cerebellum and the spinal accessory nerves coming up from the spinal cord. Just superior and lateral to the foramen magnum on each side is the hypoglossal canal. This transmits the hypoglossal nerve, see in Sorel, to control the tongue muscles. Then there's the jugular foramen, a large, irregularly shaped opening on each side, formed between the temporal and occipital bones. It's another major exit point. 3 cranial nerves pass through here: the glossopharyngeal, CNX, the vagus, CNX, and the accessory, CNI. Plus, large venous sinuses drain blood from the brain through here, becoming the internal jugular vein in the neck. And finally, piercing the petrous part of the temporal bone is the internal acoustic meatus. This is the passageway for the vestibulocochlear nerve, CN8, responsible for hearing and balance, and also the facial nerve, CN7, on its way to control facial muscles.
So again, understanding these specific openings, these foramina, and knowing what goes through them is absolutely critical for diagnosis, right? If a patient suddenly has trouble swallowing and speaking, you might think about structures passing through the jugular foramen, like the vagus nerve.
Precisely. It allows clinicians to localize lesions with remarkable accuracy. It really underscores how structure and function are inextricably linked.
Now, you mentioned earlier that the adult skull isn't how we start out. Let's touch on the neonatal skull. How is it different?
It's quite different, and those differences are really important. First, proportions. A newborn's cranium, the brain case, is disproportionately large compared to its face. The face looks quite small. It grows significantly later. The bones themselves are generally smoother, and they lack that spongy diplo layer found in adults. They are mostly single-layered, but the most striking feature is that the bones of the vault, the top and sides, aren't fused yet.
Right, they're separated by gaps.
Exactly. They're connected by fibrous tissue or cartilage, allowing for movement and growth. These unossified membranous intervals are the fontanelles.
Ah, the famous soft spots. What's their significance? Why are they there?
They serve a couple of crucial purposes. First, during birth, they allow the bony plates of the skull to overlap slightly, a process called molding. This helps the baby's head navigate the birth canal more easily. Second, and perhaps more importantly after birth, they accommodate the incredibly rapid growth of the brain during the first year or 2 of life. The brain grows faster than the bone can initially keep up. The main ones are the anterior fontanelle, which is diamond-shaped, located on top towards the front. It usually closes by about 18 months. And the posterior fontanelle, which is smaller and triangular at the back. It typically closes much earlier, usually by the end of the first year.
And you mentioned they're clinically important.
Hugely important. Because they are soft, a pediatrician can gently palpate them. If a fontanelle is bulging outwards and feels tense, it can be a sign of increased intracranial pressure, maybe due to hydrocephalus, which is fluid buildup in the brain, or meningitis, an infection. Conversely, if a fontanelle is sunken or depressed, it can be a sign of dehydration. So they provide this invaluable, non-invasive window into an infant's neurological health and hydration status. They're vital diagnostic clues that simply aren't available once the skull fuses.
So these soft spots aren't just a leftover from birth. They're active diagnostic tools for a while. Any other key developmental differences in the newborn skull?
A couple of others are worth noting. The mastoid process, that bony lump you can feel behind your earlobe, it's actually not present at birth. It develops later, during the first year or so, as the sternocleidomastoid muscle in the neck starts pulling on that area when the infant gains head control. Also the mandible, the lower jaw. At birth, it's actually in 2 halves, right and left, joined in the midline by fibrous tissue. These halves fuse together to form a single bone by the end of the first year. These developmental details aren't just trivia. They help explain certain vulnerabilities and provide diagnostic insights unique to infants and young children.
That's fascinating. Okay, we've built a solid understanding of the protective bony fortress. Let's now turn our full attention back inside to the very core of it, the brainstem itself. We're going to dive deep now into its first segment, the medulla oblongata, the lowest part, directly connected to the spinal cord.
All right, the medulla oblongata, as you said, it connects the pons above it with the spinal cord below it, making that transition right around the level of the foramen magnum. Shape-wise, it's sort of conical, wider at the top where it joins the pons. Internally, the narrow central canal that runs through the spinal cord continues up into the lower medulla, but then in the upper half, it expands dramatically to form the lower part of the cavity, known as the fourth ventricle.
Okay, what about its external features? What do we see on the surface?
On its anterior surface, running down the midline, is the anterior median fissure, continuous with the one on the spinal cord. Flanking this fissure on each side are prominent longitudinal bulges called the pyramids. These are really important. They are formed by massive bundles of descending motor fibers, the corticospinal tracts coming down from the cerebral cortex. And a key event happens low down on these pyramids. The majority of those descending motor fibers cross over to the opposite side. This is the famous decussation of the pyramids. It's the anatomical basis for why one side of your brain controls the opposite side of your body.
The great motor crossing. Got it. What else is on the anterior surface?
Just posterolateral to each pyramid, there's another oval-shaped swelling called the olive. These are produced by large nuclei lying underneath, the inferior olivary nuclei. And emerging from the groove between the pyramid and the olive are the rootlets of the hypoglossal nerve. See how much?
Okay. Now, what about the posterior surface?
The posterior surface is a bit different. Its superior half actually forms the lower part of the floor of the fourth ventricle, that shared cavity. The inferior half below the ventricle is more like the spinal cord. It has a posterior median sulcus. On each side of this sulcus, there are elongated swellings. Medially, the gracile tubercle, and laterally, the cuneate tubercle. These bumps are caused by underlying sensory nuclei, the nucleus gracilis and nucleus cuneatus, which are receiving sensory information from the body. Also visible posteriorly, especially laterally, are the inferior cerebellar peduncles. These are thick bundles of nerve fibers connecting the medulla and spinal cord to the cerebellum, which sits just behind it.
So externally, it's got quite a few distinct landmarks. But internally, you mentioned earlier, the medulla undergoes a significant rearrangement compared to the spinal cord. Can you elaborate on that?
Yes, it's a fundamental shift. If you remember the spinal cord's cross-section, it has that characteristic H shape of gray matter with motor neurons anteriorly and sensory processing posteriorly. In the medulla, this neat organization gets dramatically altered. It happens because the central canal, as I mentioned, expands dorsally to form the wide, shallow fourth ventricle. This opening up process essentially pushes the sensory components laterally and the motor components medially relative to their positions in the spinal cord. It's key to understanding the layout. We can visualize this rearrangement best by looking at transverse sections at different key levels.
Okay, so let's take those levels. First, the level of pyramid decussation.
Right, down at the lower end of the medulla. This is where that great motor crossover occurs. You see the corticospinal fibers occupying the pyramids anteriorly, and then about 3/4 of them sweep across the midline to the opposite side, forming the lateral corticospinal tract that will continue down the spinal cord. This massive crossing effectively obliterates the neat anterior horn of gray matter seen in the spinal cord. Meanwhile, the sensory tracts carrying fine touch and proprioception, the fasciculus gracilis and cuneatus, are still ascending posteriorly, heading towards their nuclei, which start to appear here.
Okay, so motor crossing low down. What about the sensory crossing? You mentioned the level of lemnisciodecussation.
Yes, this happens a bit higher up in the medulla. This is the great sensory decussation. Here, fibers arise from those gracile and cuneate nuclei, which have received the primary sensory input. These new fibers, called internal arcuate fibers, sweep anteriorly and medially. They then cross the midline, anterior to the central gray matter. Once they cross, they bundle together to form a prominent ascending pathway called the medial lemniscus. This pathway carries fine touch, vibration, and conscious proprioception up towards the thalamus. So just like the motor pathways, this critical sensory pathway also crosses over. Information from your left body goes up the right medial lemniscus and vice versa.
That's fascinating. A double crossing point, really. One for motor, one for key sensory pathways. Okay, moving up again to the level of the olives. What critical structures are packed in there? Seems like a busy area.
It is a very busy level, corresponding to the open part of the medulla with the fourth ventricle. There's a significant increase in gray matter here. Most obviously, you have the large, crumpled-looking inferior olivary nucleus deep to the olive bulge. It's involved in motor control and learning, sending lots of fibers across the midline to the cerebellum via the inferior cerebellar peduncle. But crucially, this level also contains several vital cranial nerve nuclei. Remember, the brainstem is a CN hub. Medially, beneath the floor of the fourth ventricle, you find the hypoglossal nucleus, controlling the tongue, CN12. Just lateral to that is the dorsal nucleus of the vagus. parasympathetic control of heart, lungs, gut, CNX. Further laterally are vestibular nuclei for balance, CN8. And deeper within the reticular formation lies the nucleus ambiguus. This is important. It contains motor neurons whose axons travel with the glossopharyngeal, CNIIX, vagus CNX, and accessory CNX nerves to control muscles involved in swallowing and speaking. The medial lemniscus is prominent here too, continuing its ascent, now positioned just behind the pyramid. And we also see the medial longitudinal fasciculus, MLF, a crucial pathway running near the midline, essential for coordinating eye movements with head movements.
Wow, that is an incredible concentration of critical functions. So, given all this intricate anatomy, what are the most significant clinical implications? What makes the medulla particularly vulnerable?
Well, its critical nature is its vulnerability. As we've seen, it contains nuclei essential for life-controlling heart rate, respiration via the vagus and other centers. Plus, it's the indispensable conduit for all those ascending and descending tracts. This dense packing means that even small lesions, whether from demyelinating diseases like MS, tumors, or, very commonly, vascular disorders like strokes, can have devastating consequences.
You mentioned tumors. What about pressure effects in this region?
Yes, that's a major concern, particularly raise intracranial pressure in the posterior cranial fossa. Remember, the medulla sits in that compartment below the tentorium cerebelli and just above the foramen magnum. If a tumor grows in the cerebellum or nearby, the increasing pressure has nowhere to go but down. It can force the lower parts of the cerebellum, the tonsils, and the medulla itself downward, squeezing them through the foramen magnum. This is called tonsillar herniation. The compression and stretching can cause headache, neck stiffness, but also paralysis of those lower cranial nerves, 9X, XX, AI, due to traction. And this leads to a critical point about lumbar puncture. If someone has high pressure in their head, especially suspected in the posterior fossa, doing an LP withdrawing spinal fluid from the lower back can be extremely dangerous.
Why is that?
Because suddenly lowering the pressure from below can cause the brainstem to herniate even further and faster. It removes the cushion effect. This can lead to sudden catastrophic failure of breathing and heart function as those vital medullary centers get compressed or ischemic. It's a neurosurgical emergency.
A profound warning about careful diagnostic procedures. Absolutely. What about congenital issues affecting this area?
The Arnold-Chiari malformation is a well-known example. It's a congenital condition where parts of the cerebellum, usually the consoles, and often the medulla oblongata, are displaced downward, herniating through the foramen magnum into the upper spinal canal. This often obstructs the flow of cerebrospinal fluid, CSF, out of the fourth ventricle, leading to a buildup of fluid within the brain's ventricles, a condition called hydrocephalus. Chiari malformations are frequently associated with other developmental anomalies, particularly spina bifida, where the spinal cord doesn't close properly lower down.
That connection seems distant. How can a problem in the lower spine affect the brainstem way up high?
It's a fascinating question. The leading theory involves tethering. The idea is that the spinal cord, being abnormally anchored or tethered at the site of the spina bifida defect lower down, can't ascend normally within the vertebral canal as the child grows. As the vertebral column grows longer, faster than the tethered cord, it exerts a downward pull on the entire central nervous system, literally pulling the cerebellum and medulla caudally down into the foramen magnum. This complicates CSF flow and directly impacts brainstem function.
That really helps make sense of that connection. Okay, let's circle back to vascular issues. You mentioned they are a key vulnerability for the medulla. Can you describe the specific syndromes that result from blood supply problems?
Yes, because the arterial supply to the medulla is quite specific, blockages lead to very distinct patterns of deficits or syndromes. The classic one is lateral medullary syndrome, also famously known as Wallenberg syndrome. This is typically caused by a blockage, usually a blood clot, thrombosis, in the posterior inferior cerebellar artery, PICA, which is usually a branch of the vertebral artery. PPI supplies the lateral part of the medulla. When this area loses blood supply, the resulting tissue damage causes a very characteristic constellation of symptoms. Let's list them. Patients often have severe difficulty swallowing, dysphagia, and speaking dysarthria. This is due to paralysis of muscles in the palate and larynx on the same side as the lesion, because the nucleus ambiguus is affected. They experience loss of pain and temperature sensation on the same side of the face. This is due to damage to the spinal nucleus and tract of the trigeminal nerve, CNV. Vertigo, nausea, vomiting, and nystagmus, involuntary eye movements, are common, resulting from damage to the vestibular nuclei. A key sign is ipsilateral Horner syndrome. On the same side, you see a drooping eyelid, apoptosis, a constricted pupil, miosis, and sometimes decreased sweating. This happens because the descending sympathetic fibers that control these things run through the lateral medulla and get damaged. They may also have ipsilateral cerebellar signs like ataxia, clumsiness in the limbs, or gait due to involvement of the inferior cerebellar peduncle or cerebellum itself. And very distinctively, they have loss of pain and temperature sensation on the opposite side of the body, contralateral. This is because the spinothalamic tract, carrying these sensations from the body, has already crossed lower down and ascends in the lateral medulla. Fine touch and proprioception via the medial lemniscus are usually spared because that pathway runs medially.
Wow, that is a classic example. So many specific deficits, all pointing to that lateral medullary region supplied by PICA. If you see that combination, you know exactly where the lesion is.
Precisely. It's a cornerstone of neurological localization. And contrasting with that is the medial medullary syndrome. This is what our opening case study demonstrated. It's typically caused by a blockage in a smaller medullary branch of the vertebral artery itself, which supplies the medial or inner part of the medulla. The damage here affects a different set of structures, leading to a different clinical picture. Contralateral hemiparesis weakness on the opposite side of the body. This is due to damage to the pyramidal tract before it crosses. Contralateral impairment of sensation specifically, loss of position sense, vibration sense, and fine tactile discrimination. This results from damage to the medial lemniscus after it has crossed, and as in our case, ipsilateral paralysis of the tongue muscles. The tongue deviates towards the side of the lesion when protruded. This is due to involvement of the hypoglossal nerve nucleus or its fibers on that side.
So comparing those two, lateral and medial medullary syndromes, it's just incredible. It truly illustrates the exquisite, tightly packed organization within the medulla. A blockage in a different artery, maybe just millimeters away, produces a completely different set of neurological problems.
Exactly right. It highlights why this detailed anatomical knowledge isn't just academic, it's absolutely vital for clinical diagnosis and understanding. The precision is remarkable.
Okay, we've thoroughly explored the medulla. That was incredibly detailed. Now let's move superiorly up the brainstem stalk to the next segment. The pons, aptly named the bridge. What's its general layout and how does it fit in?
Right, the pons. It sits directly anterior to the cerebellum, forming a visible bulge on the front of the brainstem. As you said, it connects the medulla oblongata below to the midbrain above. It's about an inch, maybe 2.5 centimeters long. Its name, pons, is Latin for bridge, and that perfectly describes its most striking feature on the anterior surface. You see this massive bundle of transverse fibers running across it from side to side. These fibers arch around and collect laterally to form the huge middle cerebellar peduncles. These peduncles plunge into the cerebellum, effectively bridging the two cerebellar hemispheres. That's where the name comes from. Also, in the anterior surface, usually there's a shallow vertical groove in the midline, the basilar groove, which typically lodges the basilar artery, a major blood vessel formed by the joining of the two vertebral arteries. And emerging from the anterolateral surface of the pons itself is the large trigeminal nerve, C and V, on each side. Then, importantly, in the distinct groove between the lower border of the pons and the upper border of the medulla, several other cranial nerves emerge. From medial to lateral, these are the abducens nerve, CN-xi, the facial nerve, CN-psi, and the vestibulocochlear nerve, CN-8.
Okay, that's the front. What about the posterior surface of this bridge? Is it visible?
No, the posterior surface of the pons is completely hidden from external view by the overlying cerebellum. If you were to remove the cerebellum, you'd see that the posterior surface of the pons forms the upper triangular part of the floor of the fourth ventricle. A couple of interesting features are visible on this ventricular floor. There's a midline sulcus. Lateral to that is an elevation called the medial eminence. And at the lower end of this medial eminence, there's a slight bulge called the facial colliculus. This is a fascinating landmark. It's not caused by the facial nucleus itself, but rather by the fibers of the facial nerve taking a peculiar looping course around the nucleus of the abducens nerve, CNVI, which lies deep to it. That internal loop creates the external bulge.
That's quite a detour for the facial nerve. So, like the medulla, the pons must also have a very distinct internal organization, different from just a simple bridge.
Oh, definitely. Internally, the pons is typically divided into two main regions. There's a posterior part called the tegmentum, which is essentially the continuation of the brainstem core, and there's a much larger anterior part, the basal part or basis pontis. This contains those transverse fibers and pontine nuclei we saw externally. These two regions are often described as being separated by transversely running auditory fibers called the trapezoid body.
Okay, let's look inside at different levels again. What do we see in a transverse section through the caudal part of the pons, say, at the level of that facial colliculus?
All right, in the caudal pons tegmentum, we see pathways continuing up from the medulla. The medial lemniscus is prominent, carrying those fine sensory signals, now oriented more horizontally in the anterior tegmentum. The spinal lemniscus, carrying paint temperature, is lateral to it. Auditory pathways, including the lateral lemniscus and the trapezoid body, are also present here. We find the nucleus of the abducens nerve, Ciensip soleocomita, located medially, close to the floor of the fourth ventricle. And just deep and slightly lateral to that is where the facial nerve, CN7 fibers, make that characteristic loop around the abducens nucleus, the internal structure creating the facial colliculus. The facial nucleus itself, where those fibers originated, lies more ventrolaterally in the tegmentum. The medial longitudinal fasciculus, MLF, is still there, near the midline beneath the ventricle floor, coordinating eye movements. The vestibular nuclei are located laterally, then anterior to the tegmentum is the large basilar part of the pons. This is filled with scattered gray matter, the pontine nuclei, and massive descending fiber tracts. This is a critical relay station. Corticopontine fibers come down from virtually all parts of the cerebral cortex, synapse in these pontine nuclei. The axons of these pontine nuclei then form those thick transverse fibers that cross the midline, sweep through the descending motor tracts, corticospinal and corticonuclear, and enter the middle cerebellar peduncle to reach the opposite cerebellar hemisphere. This corticopontocerebellar pathway is the main route by which the cerebral cortex communicates with the cerebellum, crucial for planning, coordinating, and refining movements, and for motor learning.
An incredibly complex relay system. What about higher up, in the cranial part of the pons? What changes?
As we move up towards the midbrain, the main nuclei associated with the trigeminal nerve, CNV, become prominent. The motor nucleus of the trigeminal nerve lies in the lateral tegmentum. It controls the muscles of mastication, chewing. Just lateral to it is the principal sensory nucleus of the trigeminal nerve. This receives fine touch and pressure sensation from the face. Pain and temperature from the face go to the spinal trigeminal nucleus, which extends down into the medulla and upper spinal cord. The superior cerebellar peduncles, which are the main output pathway from the cerebellum, become larger as they ascend towards the midbrain along the sides of the upper pons. The ascending sensory lemnisci, medial, spinal, trigeminal, lateral, continue their journey upwards through the tegmentum. The basilar part still contains pontine nuclei and descending tracts.
Okay, so another densely packed area. What are the primary clinical implications and pathologies associated with the pons? Given its location and all those functions, it must also be quite vulnerable.
Absolutely. Its location in the posterior fossa, its role as a major hub for cranial nerves V, 6, 7, and 8, and the passage of all those critical ascending and descending tracts make it susceptible to various problems. Tumors, hemorrhage, and infarcts, strokes, here can produce a wide, often complex array of symptoms. For instance, damage specifically to those corticopontocerebellar pathways we just discussed, disrupting communication between the cerebrum and cerebellum, typically results in marked cerebellar ataxia. That's clumsiness and lack of coordination. Patients might also exhibit an intention tremor, a tremor that appears or worsens when they try to perform a voluntary, precise movement, like reaching for a cup.
What about tumors that arise specifically within the pons?
Pontine gliomas, particularly astrocytomas, are unfortunately the most common type of brainstem tumor found in childhood. Because they grow within the substance of the pons, they tend to infiltrate and disrupt multiple structures, often leading to a combination of symptoms. Typically, you see ipsilateral cranial nerve palsy as weakness or dysfunction on the same side as the tumor. This could be facial muscle weakness, affecting CN7 nucleus, inability to move the eye outwards, affecting CN6 nucleus, jaw muscle weakness or facial sensory loss, affecting CNV nuclei, or even hearing impairment, affecting CN8 pathways nuclei. Along with these ipsilateral cranial nerve signs, you often see contralateral hemiparesis weakness on the opposite side of the body. This occurs because the tumor compresses or damages the descending corticospinal tracts as they pass through the pons. Depending on the exact location and size, you can also get contralateral sensory deficits from lemniscal involvement or problems with conjugate eye movements from MLF involvement. It can be a devastating diagnosis.
A huge range of potential deficits from that single location. What about hemorrhages in the pons?
Bleeding. Pontine hemorrhages are often catastrophic, frequently resulting from rupture of small branches of the basilar artery, often related to chronic high blood pressure. If the hemorrhage is relatively small and unilateral, it might cause facial paralysis on the same side due to damage to the facial nerve nucleus or fibers, and limb paralysis on the opposite side due to corticospinal tract damage, another example of a crossed deficit. Paralysis of conjugate gaze, the inability to move both eyes together horizontally towards the side of the lesion, is also common due to involvement of the abducens nucleus or related centers. However, pontine hemorrhages are often extensive and bilateral. These are usually fatal rapidly. A classic sign if the patient survives initially is the presence of pinpoint pupils.
Where you mentioned this, can you explain again how a pontine hemorrhage leads to pinpoint pupils? It seems counterintuitive.
It does seem odd, but it's a crucial localizing sign. Remember, the control of pupil size involves a balance between the sympathetic system, which dilates the pupil, and the parasympathetic system, which constricts it. The sympathetic pathways that eventually lead to pupil dilation actually descend from the hypothalamus down through the entire brainstem, including the pons, before exiting the spinal cord lower down. A large pontine hemorrhage often disrupts or destroys these descending sympathetic fibers within the pons. When the sympathetic input is knocked out, the parasympathetic system, whose signals travel with the oculomotor nerve, CN3, from the midbrain, becomes unopposed. This leads to extreme constriction of the pupils, hence pinpoint. It's a grave sign, indicating severe pontine damage. Bilateral paralysis and loss of consciousness are also typical in massive pontine hemorrhage.
A stark clinical sign. And quickly, what about infarctions or strokes in the pons?
Pontine infarcts, caused by blockage of blood supply, thrombosis or embolism, also produce deficits depending on the specific artery branch involved. Blockage of small perimedian branches tends to damage the medial structures, the corticospinal tracts, causing contralateral weakness, the pontine nuclei and fibers heading to the cerebellum, causing ataxia. Blockage of more laterally penetrating branches might affect the trigeminal nerve pathways, ipsilateral facial sensory loss or weakness, the ascending sensory lemnisci, contralateral body sensory loss, and the middle cerebellar peduncle, ipsilateral ataxia. The pattern depends precisely on the vascular territory affected.
Okay, another intricate but logical system of organization. We've journeyed through the medulla and the pons. Time to ascend to the final uppermost segment of the brainstem, the midbrain. What defines this region?
The midbrain, or mesencephalon, is the shortest segment, only about 2 centimeters or 0.8 inches long. It serves as the crucial connector between the pons and cerebellum below, and the forebrain, specifically the diencephalon thalamus and hypothalamus, above. As it ascends, its long axis actually inclines forward slightly, passing through that opening in the tentorium cerebelli we mentioned earlier. Running right through the center of the midbrain is a very narrow channel called the cerebral aqueduct, or aqueduct of Sylvius. This connects the third ventricle above it with the fourth ventricle below it, and it's filled with cerebrospinal fluid.
What are its main external features?
On its posterior surface, the most prominent features are 4 rounded swellings, collectively known as the corpora quadrigemina, meaning quadruplet bodies, or more simply, the colliculi, meaning little hills. There's a superior pair, the superior colliculi, which are important reflex centers involved in processing visual information and initiating reflex movements of the eyes, head, and neck towards visual stimuli. And there is an inferior pair, the anterior colliculi, which are crucial relay stations in the auditory pathway. They process sound information and are involved in auditory reflexes, like turning your head towards a sudden noise. Also emerging uniquely from the posterior aspect, just below the inferior colliculi, in the midline, are the very slender trochlear nerves, CNIV. They're the only cranial nerves to exit dorsally.
Okay, 4 bumps on the back. What about the front?
The anterior aspect of the midbrain is dominated by 2 massive columns of descending fibers, the crus cerebri, plural. Crura cerebri. These look like thick stalks supporting the cerebral hemispheres above. Between these 2 crura is a deep depression called the interpeduncular fossa between the peduncles. And emerging from the groove on the medial side of each crus cerebri within this fossa is the oculomotor nerve, CN3.
Got it. Now let's look inside. How is the internal structure of the midbrain organized?
Internally, the midbrain is essentially composed of those 2 lateral halves, often referred to collectively as the cerebral peduncles, though sometimes that term refers just to the anterior crus cerebri. Each half is fundamentally divided into 3 parts, from posterior to anterior. Posteriorly, behind the cerebral aqueduct, is the tectum, meaning roof, which contains the superior and inferior colliculi. The large central core area surrounding the aqueduct and extending forward is the tegmentum. This is continuous with the pontine tegmentum below, and the most anterior part is that massive fiber bundle, the crus cerebri. Separating the tegmentum from the crus cerebri is a critically important, darkly pigmented nucleus called the substantia nigra, black substance.
Okay, tectum, tegmentum, crus cerebri, with the substantia nigra in between. Let's look at the transverse sections again. What do we see at the level of the inferior colliculi?
All right, at this lower midbrain level, the inferior colliculus itself is a large nucleus, a key part of the auditory pathway. It receives input from the lateral lemniscus and relays auditory information towards the thalamus, specifically the medial geniculate body, via its output pathway, the inferior brachium. Deep in the central gray matter near the midline just ventral to the aqueduct lies the trochlear nucleus, CNIV. Its fibers take that unique course, exiting dorsally and crossing completely to the other side to supply the superior oblique eye muscle. A major feature at this level is the decussation of the superior cerebellar peduncles. These are the main output fibers from the cerebellum, carrying coordinated motor information upwards. They cross the midline here in the central tegmentum before heading mostly to the thalamus and red nucleus. The substantia nigra is prominent, a large C-shaped nucleus stretching between the tegmentum and the crus cerebri. It's packed with neurons containing melanin pigment, hence the black appearance in unstained sections. It's a crucial part of the basal ganglia circuitry, involved in motor control, particularly initiation of movement and regulating muscle tone. Its degeneration is the primary cause of Parkinson's disease. And interiorly, the crus cerebri is packed with vital descending tracts from the cerebral cortex. Roughly, the middle portion contains the corticospinal to the spinal cord and corticonuclear corticobulbar to brainstem, cranial nerve nuclei, motor fibers. The medial part contains frontopontine fibers from frontal lobe to pons, and the lateral part contains temporopontine fibers from temporal lobe, etc. to pons. These connect the cortex extensively with the pons and cerebellum.
That's a lot happening at the inferior colliculus level. What about higher up, at the level of the superior colliculi?
Okay, moving up. Now, the superior colliculus is the large nucleus in the tectum. It's involved in visual reflexes and orienting movements. It receives input directly from the retina via the optic nerve, from the visual cortex, and also from ascending sensory pathways. Its outputs, tectospinal and tectobulbar tracts, drive those reflex movements of the eyes, head, and neck towards visual and other sensory stimuli. Close to the superior colliculus is the protectal nucleus, a small but vital area. It's where the afferent limb of the pupillary light reflex synapses. Fibers from here then go bilaterally to the parasympathetic nucleus of the oculomotor nerve. And that nucleus, the parasympathetic nucleus, Edinger-Westphal nucleus, along with the main oculomotor nucleus, CN3, controlling most eye muscles, lies in the central gray matter ventral to the aqueduct near the midline. The oculomotor nerve fibers travel anteriorly from here. Another major landmark at this level is the red nucleus. This is a large, somewhat rounded nucleus situated in the tegmentum anterior to the oculomotor nucleus. It appears pinkish or reddish in fresh tissue due to high vascularity and iron pigment in its neurons. The red nucleus is another key motor control center. It receives major input from the cerebellum via the decussated superior cerebellar peduncle and the cerebral cortex. Its main output goes down to the spinal cord via the rubrospinal tract, which crosses immediately, influencing muscle tone, particularly in flexor muscles. It also connects with other motor areas. The substantia nigra and the crus cerebri, with its descending tracts, are still present and prominent at this level. The ascending sensory lemnisci, medial, spinal, trigeminal, continue their path through the tegmentum, posterior to the substantia nigra. Note that the lateral lemniscus auditory mostly terminated at the inferior colliculus level.
The midbrain is clearly another critical junction box for motor control, reflexes, and major pathways. What are its main clinical vulnerabilities and pathologies?
Well, its location makes it vulnerable. Being the narrow upper part of the brainstem stalk and having to pass through that relatively tight opening in the rigid tentorium cerebelli makes it susceptible to traumatic injury. Sudden acceleration-deceleration forces, especially rotational ones like in car accidents or falls, can cause the midbrain to shear or compress against the sharp edge of the tentorium. This can lead to tearing of fibers, hemorrhages, or diffuse axonal injury, often resulting in coma or severe neurological deficits.
And what about lesions affecting its specific nuclei?
Damage to the oculomotor nucleus, CN3, or its nerve fibers, causes ipsilateral oculomotor palsy. The eye looks down and out due to paralysis of most extraocular muscles. The eyelid droops. ptosis, and the pupil is usually dilated and unresponsive to light because the parasympathetic fibers traveling with CN3 are also affected. That's the Edinger-Westphal nucleus component. Damage to the trochlear nucleus, CNRV, or its nerve, remembering it crosses, causes contralateral superior oblique muscle palsy. This results in difficulty looking down and inwards, often causing vertical double vision, especially noticeable when reading or going downstairs. Patients might tilt their head away from the affected side to compensate, so impairments of eye movements are common signs of midbrain lesions.
You mentioned the cerebral aqueduct running through it. What happens if that gets blocked? That seems like a precarious bottleneck.
It absolutely is a bottleneck. The cerebral aqueduct is one of the narrowest points in the entire pathway for cerebrospinal fluid flow. If it becomes blocked or narrowed, aqueductal stenosis, may be due to congenital malformation, infection, hemorrhage, or compression by a tumor either within the midbrain, like a tectoglioma, or nearby CSF can't flow from the third ventricle down to the fourth ventricle. The result is that CSF backs up in the third and lateral ventricles above the blockage, causing them to enlarge. This is a common cause of hydrocephalus, particularly non-communicating hydrocephalus. The increased pressure can damage surrounding brain tissue, but importantly, the symptoms caused by the lesion itself in the midbrain, like the eye movement problems we just discussed, or damage to descending motor tracts, can provide crucial clues to localize the blockage to the midbrain level.
That highlights a fascinating, almost mechanical vulnerability. A blockage in this tiny pipe can have huge consequences. Okay, let's wrap up the midbrain with vascular lesions. Are there specific midbrain syndromes, like we saw in the medulla and pons?
Yes, there are classic midbrain vascular syndromes, often resulting from blockage of branches of the posterior cerebral artery or the basilar artery tip, which supply this region. The first is Weber syndrome. This typically involves damage to the ventral part of the midbrain. The lesion affects the emerging oculomotor nerve, CM3 fibers, and the adjacent crus cerebri. This combination produces 1. Ipsilateral oculomotor palsy, eye down and out, a ptosis dilated pupil due to CN3 damage. 2. Contralateral hemiparesis, weakness of the opposite face, arm, and leg, due to damage to the corticospinal and corticonuclear tracts in the crus cerebri.
Weber syndrome, another textbook example of a highly localized vascular event producing that characteristic crossed paralysis. One side eye face, opposite side body, it really hammers home the anatomy.
Precisely. And then there's Benedict syndrome. This lesion is typically located more dorsally in the midbrain tegmentum compared to Weber's. It also often involves the oculomotor nerve pathways, but crucially, it damages the red nucleus and often the medial lemniscus. So in addition to a possible ipsilateral CN3 palsy, patients with Benedict syndrome exhibit 1. Contralateral hemianesthesia, loss of sensation on the opposite side of the body due to medial lemniscus damage. 2. Contralateral involuntary movements, such as tremor, chorea, jerky movements, or athetosis, slow writhing movements. This is attributed to the damage involving the red nucleus and its connections.
So that's where it gets even more nuanced. Just a slightly different area of damage, deeper in the tegmentum involving the red nucleus, adds that whole layer of involuntary movement disorders. It really shows the complex role these midbrain structures play in motor control and coordination.
Exactly. These syndromes, Weber's and Benedict's, along with others involving the dorsal midbrain, like Perronneau syndrome affecting vertical gaze via the colliculi, demonstrate how precise knowledge of the midbrain's internal architecture is essential for clinical neurology.
Connecting the dots across the brainstem.
What an absolutely incredible detailed journey through these three segments, the medulla, the pons, and the midbrain. It's clear that while we break them down for study, they really function as one continuous integrated unit, don't they? The pathways just flow right through.
Absolutely. That's a crucial takeaway. There's a remarkable continuity. You see the cranial nerve nuclei arranged in reasonably logical columns, more or less, throughout the brainstem. Motor nuclei tend to be more medial, sensory more lateral, reflecting that developmental pattern we discussed. And the major ascending sensory tracts, like the lemnisci, and descending motor tracts, like the corticospinal tract, are weaving their way consistently through all three segments, maybe changing positions slightly, but providing that essential connection between the brain and the body. Understanding the brainstem isn't just about memorizing the parts of the medulla, then the pons, and the midbrain in isolation. It's truly about appreciating the elegant critical design of this system, seeing how every millimeter, every pathway, every nucleus matters and connects to the whole. That holistic view, understanding those dynamic relationships between structure and function, that's what leads to real mastery.
And it seems like that level of understanding, getting down to the precise location of specific nuclei and tracts, is absolutely fundamental. It's the key to diagnosing these complex neurological conditions we've discussed, from the opening case of medial medullary syndrome to Wallenberg, Weber, Benedict.
Precisely. It allows you to take a patient's symptoms, a specific pattern of weakness, sensory loss, cranial nerve dysfunction, and mentally overlay it onto the brainstem's anatomy. You can visualize the pathways, predict which structures must be involved, and pinpoint the likely location of the lesion. It turns diagnosis from guesswork into a deductive science based on anatomical principles. Whether you're a clinician facing a patient, a researcher trying to understand neural circuits, or simply a curious mind wanting to grasp how this vital part of you works, that deep anatomical mastery provides the foundation for profound insight.
Well, you have definitely completed a true deep dive today. We didn't just skim the surface. We navigated the intricate pathways, the crucial nuclei, the protective fortress of the skull. Everything that makes the brainstem the remarkable, vital control center it is. We've charted the skull's anatomy, from the clinically vital Paterian to the diagnostic window of the fontanelles. We dissected the medulla, the pons, the midbrain, seeing how tiny lesions can cause specific syndromes like Wallenberg's or Weber's. Hopefully, you've moved beyond just surface-level knowledge now, armed with some surprising facts, and more importantly, that kind of interconnected understanding that really separates the merely informed from the truly insightful. You've seen how tiny details translate to big impacts in the real world.
And as you reflect on all this incredible complexity, the vital functions packed into such a small space, the specific vulnerabilities maybe consider this question. While we focused a lot on the predictable outcomes when specific parts are damaged, the brain also has this remarkable capacity for plasticity, for reorganization, for recovery, even after injury to these critical areas. That often adds another layer of complexity to the clinical picture. So what does that interplay between predictable damage and unpredictable recovery tell us about the future? How might it shape neurorehabilitation or the development of even more precise medical interventions targeting the brainstem? Our understanding is constantly evolving, pushing the boundaries.
A truly profound thought to leave you with, the intersection of intricate structure and the potential for change. Thank you for joining us on the deep dive. We hope this exploration has been a valuable shortcut to being truly well-informed on the brainstem and skull. Join us next time for another deep dive into the fascinating world of knowledge.